block simulation 12. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Which factor was changed and how is it defined? A physiologist measures cardiac parameters in a healthy volunteer. Stroke volume is determined by 3 factors. The volunteer is given a drug that increases contractility without changing heart rate, preload or afterload, and stroke volume rises. Read the command, which factor and its definition. A drug raising contractility without changing preload, afterload, or heart rate, increasing stroke volume, contractility. Stroke volume is governed by 3 independent factors: preload, afterload, and contractility. The question isolates one. A drug that raises stroke volume while holding preload, afterload, and heart rate constant must be acting on contractility. Contractility, or inotropy, is the intrinsic strength of ventricular contraction at any given preload, independent of how full the ventricle is. Increasing contractility shifts the entire Frank-Starling curve upward, ejecting more blood from the same end diastolic volume. The correct answer is A. Distinguish the 3. Preload is the end diastolic volume, the degree of stretch before contraction, Frank-Starling. Afterload is the resistance the ventricle ejects against, mainly arterial pressure. Contractility is the inherent vigor of contraction. Contractility is raised by sympathetic stimulation, catecholamines, and digoxin, and lowered by beta blockers, heart failure, and acidosis. A pure rise in stroke volume with everything else fixed points to increased contractility. What is the earliest event in the pathogenesis of this lesion? A 60-year-old man with hypertension, diabetes, and a 40-pack-year smoking history dies of a myocardial infarction. At autopsy, his coronary arteries show plaques with a lipid-rich core containing foam cells, a fibrous cap, and calcification. Read the command. Earliest event in pathogenesis: atherosclerotic plaque with foam cells and fibrous cap. The earliest step is endothelial injury, allowing LDL entry and foam cell formation. Atherosclerosis begins with endothelial injury or dysfunction caused by the chronic insults of hypertension, smoking, hyperlipidemia, and diabetes, especially at sites of turbulent flow. The damaged endothelium becomes permeable and lets LDL enter the intima, where it is oxidized. Monocytes adhere, migrate in, become macrophages, and engulf the oxidized LDL, transforming into FOM-CLLs. Aggregations of foam cells form the earliest visible lesion, the fatty streak. Over time, smooth muscle cells migrate in and lay down a fibrous cap, producing the mature atheromatous plaque seen here. The correct answer is B. The sequence is testable in order: endothelial injury, then LDL entry and oxidation, then foam cell and fatty streak formation, then smooth muscle proliferation and fibrous cap formation, and finally the complications: calcification, plaque rupture, and thrombosis causing myocardial infarction. The fatty streak is the earliest lesion, but the earliest event is the endothelial dysfunction that permits it. Endothelial injury initiating LDL entry and foam cell formation is the answer. Which vitamin deficiency is responsible? A 28-year-old woman who is 8 weeks pregnant did not take prenatal vitamins. She has a history of poor diet and takes an anti-epileptic that interferes with this vitamin. Her fetus is later found to have a neural tube defect, spina bifida. Her own lab showed macrocytic anemia with hypersegmented neutrophils but normal methylmalonic acid. Read the command. Which vitamin deficiency? Pregnancy, neural tube defect, macrocytic anemia with hypersegmented neutrophils, but normal methylmalonic acid, folate deficiency. Folate deficiency causes macrocytic megaloblastic anemia with hypersegmented neutrophils because folate is needed for DNA synthesis like B12. The 2 distinguishing features here both point to folate. First, the neural tube defect, adequate folate in early pregnancy, is essential for neural tube closure, which is why folate supplementation is recommended before and during early pregnancy. Second, the normal methylmalonic acid, folate, is not involved in the methylmalonyl-CoA reaction, so MMA stays normal in folate deficiency, whereas it would be elevated in B12 deficiency. The correct answer is C. The lab discriminator is methylmalonic acid, normal in folate deficiency, elevated in B12 deficiency, while homocysteine is elevated in both. Folate deficiency develops relatively quickly months because body stores are small and is precipitated by pregnancy, poor diet, alcoholism, and drugs like methotrexate, trimethoprim, and certain antiepileptics phenytoin that impair folate. The neural tube defect with normal MMA is the folate signature. Which nerve is being targeted and from which roots does it arise? An obstetrician performs a regional nerve block to provide anesthesia to the perineum, lower vagina, and vulva during the second stage of labor by injecting near the ischial spine. Read the command. Which nerve and roots block near the ischial spine for perineal vulvar anesthesia in labor? Pudendal nerve, S2, S4. The pudendal nerve, arising from sacral roots S2, S3, and S4, provides the main sensory and motor innervation to the perineum, including the external genitalia, lower vagina, and the external anal and urethral sphincters. During a pudendal nerve block in labor, the anesthetic is injected near the ischial spine, where the pudendal nerve loops around the sacrospinous ligament, a reliable landmark palpable through the vaginal wall. This anesthetizes the perineum for the second stage of labor and for procedures like episiotomy. The correct answer is A. The mnemonic is S2, 3, 4. Keep the genitals off the floor, the sacral roots that supply the pudendal nerve and control the pelvic floor, continence, and erection. The ischial spine landmark is the key procedural detail. The other nerves listed supply different territories: the femoral and obturator, the thigh, the genitofemoral and iliohypogastric, the lower abdomen and upper groin. Perineal anesthesia at the ischial spine targets the pudendal nerve. What is this change, and what is its main clinical significance? A 55-year-old man with a 10-year history of chronic heartburn and acid regurgitation undergoes upper endoscopy. Biopsy of the distal esophagus shows replacement of the normal stratified squamous epithelium with columnar epithelium containing goblet cells. Read the command, what the change is and its significance. Chronic GERD, distal, esophageal, squamous epithelium replaced by columnar epithelium with goblet cells, Barrett esophagus, risk of adenocarcinoma. This is Barrett esophagus, intestinal metaplasia of the lower esophagus. Chronic acid reflux from GERD repeatedly injures the normal stratified squamous epithelium of the distal esophagus. In response, it undergoes metaplasia, switching to a more acid-resistant columnar epithelium containing goblet cells, like intestinal lining. Metaplasia is an adaptive, reversible change of one cell type to another. Its clinical significance is that Barrett esophagus is a pre-malignant condition. It predisposes to esophageal adenocarcinoma, so patients need endoscopic surveillance for dysplasia. The correct answer is A. Note the two types of esophageal cancer and the risk factors. Barrett esophagus from GERD leads to adenocarcinoma in the distal esophagus, whereas smoking and alcohol cause squamous cell carcinoma in the upper mid-esophagus. The progression in Barrett is metaplasia, then dysplasia, then carcinoma. Columnar epithelium with goblet cells from chronic reflux is Barrett esophagus, predisposing to adenocarcinoma. What is the underlying mechanism of the glucosuria? A diabetic patient has a blood glucose of 300 megadl and spills glucose into the urine. A physiologist explains that glucose is normally completely reabsorbed in the proximal tubule until a certain plasma level is exceeded. Read the command, mechanism of glucosuria. Hyperglycemia exceeding the threshold, glucose in urine, saturation of proximal tubule, glucose transporters, DM exceeded. Glucose is freely filtered at the glomerulus and then completely reabsorbed in the proximal tubule by SGLT cotransporters, as long as the filtered load is within their capacity. These transporters have a finite transport maximum, the TM. When plasma glucose rises high enough, the renal threshold, around 80 to 200 milligrams per deciliter, the filtered glucose load exceeds the transporter's reabsorptive capacity. They become saturated. Any glucose beyond what the saturated transporters can reclaim stays in the tubule and is excreted in the urine, glucosuria. The correct answer is C. This transport maximum concept explains why glucosuria appears in uncontrolled diabetes once plasma glucose passes the renal threshold. The glucose titration curve shows reabsorption rising linearly with filtered load until the TM plateau is reached, after which excretion climbs. SGLT2 inhibitors exploit this by deliberately lowering the threshold to dump glucose in the urine. Exceeding the transport maximum and saturating the transporters is the mechanism of glucosuria. What is the mechanism and a key benefit of this drug class in heart failure post-MI? A 62-year-old man with a recent myocardial infarction and reduced ejection fraction is started on metoprolol. He is counseled it improves survival. He also has mild asthma, prompting caution. Read the command, mechanism, and benefit of metoprolol post-MI. Beta-1 blockade reducing rate, contractility, and oxygen demand with remodeling benefit. Metoprolol is a beta-1 selective adrenergic antagonist. By blocking beta-1 receptors in the heart, it slows the heart rate, negative chronotropy, and reduces contractility, negative inotropy, which lowers myocardial oxygen demand, beneficial in ischemic heart disease and after a myocardial infarction. In heart failure with reduced ejection fraction, beta blockers provide a long-term mortality benefit by blunting the chronic sympathetic overdrive that drives adverse cardiac remodeling. They also prolong diastolic filling time and have antiarrhythmic effects. The correct answer is E. The ESMA caution is the reason for selecting a beta-1 selective agent. Non-selective beta blockers also block beta-2 receptors in the bronchial smooth muscle, which can trigger bronchospasm. Even beta-1 selective agents lose selectivity at high doses, so they are used cautiously in asthma. Beta blockers reduce oxygen demand and improve survival through anti-remodeling effects. The core post-MI and heart failure benefit. Which protein is overexpressed, and what does it do? A 55-year-old man presents with painless, waxing and waning lymphadenopathy in the neck and groin over many months. Excisional biopsy shows a nodular proliferation of small Queeb lymphocytes that efface the node. Flow cytometry shows CD20 positive B cells, and cytogenetics reveal a Ty14/18 translocation with overexpression of an anti-apoptotic protein. Read the command. Which protein and its function? Waxing, waning, painless lymphadenopathy, nodular small Queeb B cells, T14, 18 follicular lymphoma, BCL2 overexpression inhibiting apoptosis. This is follicular lymphoma, the most common indolent non-Hodgkin lymphoma in adults. It is defined by the 214/18 translocation, which moves the BCL2 gene on chromosome 18 next to the immunoglobulin heavy chain promoter on chromosome 14. This drives overexpression of BCL2, an anti-apoptotic protein. Normally, BCL2 restrains programmed cell death. When overexpressed, it blocks apoptosis, so the B cells do not die on schedule and accumulate. Notably, the mechanism is not faster proliferation, but failure to die, prolonged survival of the clone. The correct answer is D. The clinical hallmark is indolent, painless, waxing and waning lymphadenopathy over months to years. Follicular lymphoma can transform into aggressive diffuse large B-cell lymphoma. Match the translocations follicular lymphoma. Follicular lymphoma, 18 follicular anti-apoptosis, CMYC28, 14 Burkitt proliferation, cyclin D1 to 11, 14 mantle cell, BCR, ABLT9 to 11, 14 mantle cell, 1114 mantle cell, DT01T, AT01 lymphoma. Match the translocations BCL2 defines follicular lymphoma. How does this organism survive the acidic stomach, and what is a feared long-term complication? A 48-year-old man presents with chronic burning epigastric pain that improves with meals and occasional melena. Endoscopy shows a duodenal ulcer. Biopsy of the gastric antrum shows a curved gram-negative rod, and a rapid urease test is strongly positive. Read the command, how the organism survives acid and a feared complication. Duodenal ulcer, curved gram-negative rod, urease positive. Helicobacter pylori, urease neutralizes acid, risks, MALT, lymphoma, and gastric cancer. Helicobacter pylori is a curved gram-negative rod that colonizes the gastric mucosa. It survives the acidic stomach by producing urease, an enzyme that splits urea into ammonia and carbon dioxide. The ammonia neutralizes the surrounding gastric acid, creating a protective alkaline microenvironment around the bacterium. This urease activity is also the basis of the urea breath test and the rapid urease test used for diagnosis. By damaging the mucosal barrier, H. pylori causes chronic gastritis and peptic ulcers, both duodenal and gastric. The correct answer is C. The feared long-term complications are the high yield point. Chronic H. pylori infection is a major risk factor for gastric adenocarcinoma and, distinctively, for gastric malt lymphoma, a marginal zone B-cell lymphoma that can actually regress with antibiotic eradication of the organism. Treatment is triple or quadruple therapy with a PPI plus antibiotics. Urease-mediated acid neutralization and the cancer malt lymphoma risk define H. pylori. Which set of actions correctly describes the effects of PTH? A patient with chronic kidney disease has a low serum calcium. In response, the parathyroid glands secrete more parathyroid hormone, PTH. Read the command. Which actions describe PTH? PTH raises calcium via bone resorption, renal calcium reabsorption, phosphate excretion, and vitamin D activation. Parathyroid hormone is the body's main regulator for RA-acing serum calcium, and it acts on 3 targets. In bone, PTH stimulates osteoclast-mediated resorption indirectly via osteoblast RNKL, releasing calcium and phosphate. In the kidney, it increases calcium reabsorption in the distal tubule while increasing PHO's passate excretion. It is phosphatoric. And in the kidney, it stimulates 1-alpha hydroxylase to activate vitamin D to calcitriol, which then increases intestinal calcium absorption. The net effect is a rise in serum calcium and a fall in serum phosphate. The correct answer is D. The signature of PTH action is that it raises calcium but lowers phosphate, because the phosphate released from bone is more than offset by the phosphatoric effect at the kidney. This contrasts with vitamin D, which raises both calcium and phosphate. In chronic kidney disease, the failing kidney cannot excrete phosphate or activate vitamin D, driving secondary hyperparathyroidism. PTH increasing bone resorption, renal calcium reabsorption, phosphate excretion, and vitamin D activation is the correct set. What is the most likely diagnosis? A 24-year-old man presents with an episode of gross hematuria cola-colored urine occurring 1-2 days after the onset of an upper respiratory infection. He has had similar episodes. BP is normal. Labs, normal complement levels. Renal biopsy shows mesangial proliferation with IgA deposits in the mesangium on immunofluorescence. Read the command, most likely diagnosis, gross hematuria. 1-2 days after URI, normal complement, mesangial IgA deposits, IgA nephropathy. This is IgA nephropathy, Berger disease, the most common cause of glomerulonephritis worldwide. The hallmark presentation is episodic gross hematuria, cola-colored urine, occurring within 1 to 2 days of an upper respiratory or GI infection, so-called synpharyngitic hematuria, because it coincides with the infection rather than following it by weeks. The diagnosis rests on the biopsy, mesangial proliferation with IgA immune complex deposits in the mesangium on immunofluorescence. Serum complement levels are normal. The correct answer is E. The key distinction is from post-streptococcal glomerulonephritis, choice C. Post-strep GN follows a streptococcal infection by 1 to 3. weeks, not days, has LOW complement, C3 consumed, and shows subepithelial humps with granular IgG and C3. IgA nephropathy is concurrent with infection, has normal complement, and shows mesangial IgA. The timing days, not weeks, normal complement, and mesangial IgA deposits define IgA nephropathy. At which location do these aneurysms most commonly occur? A 50-year-old woman with adult polycystic kidney disease presents with the worst headache of my life, sudden in onset, with neck stiffness and photophobia. CT shows blood in the subarachnoid space. Angiography reveals a saccular aneurysm at a branch point of the circle of Willis. Read the command, most common location of these aneurysms. Thunderclap headache, subarachnoid hemorrhage, ADPKD, saccular aneurysm of the circle of Willis, most common at the anterior communicating artery. Saccular, Berry, aneurysms occur at branch points of the circle of Willis, where arterial wall stress is highest, and the single most common site is the anterior communicating artery. Rupture causes a subarachnoid hemorrhage, presenting as a sudden, severe thunderclap headache, the worst headache of my life, with meningeal signs like neck stiffness and photophobia, and blood in the subarachnoid space on CT. Berry aneurysms are associated with autosomal dominant polycystic kidney disease, as in this patient, as well as Ehlers, Danlos, and Marfan syndromes. The correct answer is B. Know the localizing complications. An anterior communicating artery aneurysm can compress the optic chiasm, causing visual field defects, while a posterior communicating artery aneurysm classically causes a CN3 palsy, down and out eye, dilated pupil. The triad of a thunderclap headache, subarachnoid blood, and ADPKD points to a ruptured Berry aneurysm, most often at the anterior communicating artery. Which of the following is not a required element for him to have decision-making capacity? A 35-year-old man with no psychiatric history is admitted with appendicitis requiring urgent surgery. He understands his diagnosis, the proposed operation, the risks and benefits, and the alternatives, and he communicates a consistent choice to proceed. Read the command, which is not required for capacity. The 4 elements of capacity versus a court declaration. Capacity is a clinical determination, not a court ruling. Decision-making capacity is a clinical determination made at the bedside, and it has 4 components. The patient must understand the relevant information about the condition and treatment, appreciate the situation and how it applies to them and its consequences, reason through the options in a logical way, and communicate a clear and consistent choice. This patient meets all 4. What is not required is a formal court declaration that describes legal competence, a judicial determination, which is distinct from clinical capacity. The correct answer is D. The key distinction is capacity versus competence. Capacity is clinical, decision-specific, and can fluctuate, assessed by a physician for a particular decision at a particular time. Competence is a global legal status determined by a court. Physicians assess capacity, only courts declare incompetence. The 4 bedside elements, understanding, appreciation, reasoning, and communicating a choice, are what is required. A court declaration is not. A defect in which protein underlies this disorder? A newborn sustains multiple long bone fractures during a normal delivery. Over the first year, he has recurrent fractures with minor trauma. Exam shows BLU sclerosis, and as he grows, he develops hearing loss and abnormal brittle teeth. There is a family history and an autosomal dominant pattern. Read the command, which protein? Recurrent fractures, loose sclerosis, hearing loss, brittle teeth, autosomal dominant, osteogenesis imperfecta, type I collagen defect. Osteogenesis imperfecta is caused by a defect in TYPE. Collagen, most commonly an autosomal dominant mutation in the COL1A1 or COL1A2 gene. Type I collagen is the main structural protein of bone, but also sclera, teeth, dentin, tendons, and the ear. A defect makes all these tissues fragile. hence the classic tetrad, brittle bones with recurrent fractures from minimal trauma. BLU sclerae, the thin defective sclera lets the underlying choroidal veins show through, conductive hearing loss, abnormal middle ear ossicles, and dental imperfections, brittle discolored teeth. The correct answer is B. The blue sclerae are the most classic single clue. Type I collagen is the bone, collagen. Remember, type I HBON. Osteogenesis imperfecta can mimic child abuse because of the multiple fractures, so recognizing the blue sclerae and family history is important. Contrast with Marfan fibrillin 1 and Alport type IV collagen. The fragile bones with blue sclerae and brittle teeth point to a type I collagen defect. What is the most likely diagnosis? A 60-year-old woman presents with abdominal distension, bloating, and early satiety for 3 months. Exam reveals ascites and a palpable adnexal mass. CA-225 is markedly elevated. She has a family history of breast cancer. Biopsy of the ovarian mass shows malignant epithelial cells forming papillary structures with laminated calcified concretions, seminal bodies. Read the command. Most likely diagnosis. Older woman, ascites, adnexal mass, high CA25, papillary epithelial tumor with seminal bodies, serous cystadenocarcinoma of the ovary. This is serous cystadenocarcinoma, the most common type of malignant ovarian tumor, an epithelially surface ovarian cancer. It typically presents late in postmenopausal women with vague symptoms, bloating, early satiety, abdominal distension, and ascites and an adnexal mass because there is no good early screening. The tumor marker is CA25, elevated here. The histology is characteristic, malignant epithelial cells forming papillary structures, often with P-samoma bodies, laminated concentric calcified concretions. It is frequently bilateral. The correct answer is C. The family history of breast cancer hints at a BRCA association, which markedly raises the risk of serous ovarian carcinoma. Samoma bodies are a useful but non-specific clue. They also appear in papillary thyroid carcinoma, meningioma, and mesothelioma. The combination of a postmenopausal adnexal mass with ascites elevated CA25 papillary architecture and samoma bodies points to serocystadenocarcinoma of the ovary. What explains the difference in response to oxygen? 2 hypoxemic patients are given 100% supplemental oxygen. Patient X, with a pure ventilation perfusion mismatch from a small pneumonia, corrects his PaO2 substantially. Patient Y, with a large right to left intracardiac shunt, shows little improvement in PaO2 despite 100% oxygen. Read the command. Explain the difference in oxygen response. VSQ mismatch corrects with O2. A true shunt does not because shunted blood bypasses ventilated alveoli. The response to 100% oxygen distinguishes a VAQ mismatch from a true shunt. And a VAQ mismatch is oxygen responsive, is NGH1 MISA are still ventilated, just poorly matched to perfusion. Giving 100% oxygen raises the oxygen in those ventilated units enough to substantially correct the PaO2, so VAQ mismatch is oxygen responsive. In a true right to left shunt, a portion of blood completely bypasses ventilated alveoli. It never contacts oxygen, so no matter how much oxygen you give to the alveoli, that shunted blood cannot pick it up. The deoxygenated shunt blood mixes back in, and the PaO2 barely improves. The correct answer is E. This is a classic clinical test, hypoxemia, that corrects with 100% oxygen is a VRQ mismatch or hypoventilation, while hypoxemia that does not correct with 100% oxygen indicates a true shunt, such as a right-to-left cardiac shunt, severe ARDS, or complete atelectasis. The failure to respond to oxygen is the fingerprint of a shunt because the blood never reaches the oxygen. Bypassing ventilated alveoli is why the shunt does not correct. What is the most likely diagnosis and its characteristic behavior? A 68-year-old man with extensive sun exposure presents with a slowly growing, pearly, flesh-colored nodule on his nose with rolled, raised borders, central ulceration, and overlying telangiectasias. Biopsy shows nests of basaloid cells with peripheral palisading. It has never metastasized despite years of growth. Read the command, diagnosis and behavior. Sun-exposed, pearly nodule with rolled borders, telangiectasias, central ulcer, basaloid nest with peripheral palisading, never metastasizes, basal cell carcinoma. This is basal cell carcinoma, the most common cancer in humans. It arises in sun-exposed skin, classically the face and nose, as a slow-growing pearly or flesh-colored papule or nodule with characteristic rolled raised borders, overlying telangiectasias, and sometimes central ulceration, the rodent ulcer. Histology shows nests of basaloid cells with characteristic peripheral palisading, the outer cells lined up like a fence. Its defining behavior is that it is locally invasive and can be destructive if neglected, but it almost never metastasizes. The correct answer is D. Contraste to non-melanoma. Skin cancers. Basal cell carcinoma is pearly with rolled borders and telangiectasias and rarely metastasizes, while squamous cell carcinoma is a scaly, ulcerated, or crusted lesion that arises from actinic keratosis and can metastasize, with keratin pearls on histology. Both are UV-driven. The pearly nodule with rolled borders, telangiectasias, and palisading basaloid cells that does not metastasize is basal cell carcinoma. What is this drug, its mechanism, and the serious risk? A 54-year-old man with newly diagnosed type 2 diabetes is started on first-line oral therapy. He is counseled that the drug does not cause hypoglycemia or weight gain, but must be held before contrast imaging and in renal impairment due to a rare but serious risk. Read the command, drug, mechanism, serious risk, first-line oral diabetes drug, no hypoglycemia or weight gain, held before contrast and in renal impairment. Metformin decreases gluconeogenesis, risk of lactic acidosis. This is metformin, the first-line oral agent for type 2 diabetes. Its main mechanism is decreasing hepatic gluconeogenesis, reducing the liver's glucose output, and increasing peripheral insulin sensitivity, partly through activation of AMP-activated protein kinase. Because it does not stimulate insulin secretion, metformin does not cause hypoglycemia, and it is weight neutral or promotes mild weight loss, both advantages making it first line. The serious rare adverse effect is L-acidic acidosis, which is why it is held before iodinated contrast and avoided in significant renal impairment where the drug and lactate can accumulate. The correct answer is A. The contrast and renal precautions exist because impaired renal clearance raises the lactic acidosis risk. Contrast metformin with the sulfonylureas like glipizide choice D, which close potassium. ATP channels to stimulate insulin release and therefore can cause hypoglycemia and weight gain. Metformin's gluconeogenesis, lowering mechanism, lack of hypoglycemia, and lactic acidosis risk make it the answer. Which virus is responsible? A newborn has microcephaly, periventricular intracranial calcifications, hepatosplenomegaly, a petechial blueberry muffin rash, and sensorineural hearing loss. Later in life, an immunocompromised patient infected with the same virus develops retinitis and esophagitis. Histology shows enlarged cells with intranuclear owl eye inclusions. Read the command. Which virus? Congenital periventricular calcifications, owl eye inclusions, retinitis, esophagitis in immunocompromised. Cytomegalovirus. Cytomegalovirus is a herpes virus and the most common congenital infection. Congenital CMV classically causes microcephaly with periventricular intracranial calcifications, sensorineural hearing loss. The leading infectious cause, hepatosplenomegaly, and a petechial blueberry muffin rash. The diagnostic histology is enlarged cytomegalic, cells with intranuclear OWL, EYE, inclusion bodice cytomegalic, cells with intranuclear OWL, EYE, inclusion bodies. In immunocompromised patients, especially AIDS with CD4 below 50 or transplant recipients, CMV reactivates to cause retinitis, mido, pizza pie, retinopathy, esophagitis, colitis, and pneumonitis. The correct answer is E. A useful contrast for congenital intracranial calcifications. CMV causes pure ventricular calcifications, whereas congenital toxoplasmosis causes diffuse, scattered intracranial calcifications with chorioretinitis and hydrocephalus. The owl eye intranuclear inclusions are the signature histologic finding for CMV. Congenital periventricular calcifications plus owl eye inclusions plus immunocompromised retinitis points to cytomegalovirus. Treat with ganticloviri over cranial calcifications with chorioretinitis and hydrocranial calcifications with chorioretinitis. What is the underlying immunologic target? A 28-year-old woman presents with fluctuating muscle weakness that worsens with sustained activity and improves with rest. She has drooping eyelids, ptosis, and double vision that worsen toward the end of the day, and difficulty chewing. Repetitive nerve stimulation shows a DEC remental response. CT of the chest shows a thymic mass. Read the command. Immunologic target. Fatigable weakness, worse with use, ptosis, diplopia, decremental response, thymic mass, myasthenia gravis, anti-acetylcholine receptor antibodies. Myasthenia gravis is an autoimmune disease in which autoantibodies target the postsynaptic acetylcholine receptor at the neuromuscular junction. The antibodies block and destroy these receptors, so fewer are available for acetylcholine to bind. With repeated stimulation, acetylcholine release declines as normal, but with fewer receptors there is less reserve. So muscle strength fades with sustained use and recovers with rest. This produces the hallmark of fatigable weakness, ptosis, diplopia, and difficulty chewing that worsen toward the end of the day. Repetitive nerve stimulation shows a decremental response. The correct answer is B. The thymic abnormality, thymoma, or thymic hyperplasia, is strongly associated, and thymectomy can help. The crucial contrast is with Lambert-Eaton syndrome, where antibodies hit the posynaptic calcium channel and weakness, I improves with use, and I incremental response. Myasthenia gravis worsens with use, Lambert-Eaton improves with use, Lambert-Eaton improves with use. Postsynaptic anti-acetylcholine receptor antibodies with use. Postsynaptic anti-acetylcholine receptor sign babysit. Treat with acetylcholinesterase inhibitors like pyridostigmine. Block 12 is done. Let's review the 5 biggest traps from this block. Trap 1. Folate versus B12. Both cause megaloblastic anemia, but folate deficiency causes neural tube defects with normal methylmalonic acid, while B12 deficiency causes neurologic damage with elevated MMA. The MMA tells them apart. Trap 2. IgA nephropathy follows an infection by days with normal complement and mesangial EGA. Post-streptococcal glomerulonephritis follows by weeks with low complement. The timing and complement separate them. Trap 3. Decision-making capacity is a clinical bedside determination with 4 elements. Competence is a legal status declared by a court. Physicians assess capacity, they do not declare competence. Trap 4. Hypoxemia from a VIQ mismatch corrects with 100% oxygen, but a true shunt does not because the blood bypasses ventilated alveoli. Failure to improve on oxygen signals a shunt. Trap 5. Myasthenia gravis has postsynaptic acetylcholine receptor antibodies and weakness that worsens with use. Lambert-Eaton has presynaptic calcium channel antibodies and weakness that improves with use. Worsens versus improves. 12 blocks. 240 questions. Train process, not memorization. StepLogic, learn how to think, not memorize.